like I said, my name is Ashley D. Turbert, and I am the program manager for NYUUJ, or as we affectionately call it, NUJ. Um, it is my honor and pleasure to welcome you to our Medical Aid in Dying information session. Um, as you may or may not know, NYUUJ has a few primary focus issues that we are advocating for: environmental justice, housing justice, criminal justice reform, and of course, medical aid in dying. And so we wanted to get things rolling in this month of November by getting to have some more information on this particular topic, getting to learn more about it, and learning how we as New Yorkers can advocate for this in our state. I would like to give a special hello to some of our board members who are here. I know we have Peggy Sherman, Kimberly Johnson, Claire DeRoche, Michael Tino. Trying to see if we have other board members on our call yet. Yes, Sally Hamlin is here as well. So a special thank you to them for their great work, and a special thank you to all of you for showing up tonight. And so I don't want to delay us any further, and so allow me to introduce Corinne Carey from Compassion and Care, or Compassion and Choices, sorry, who will be telling us a bit about this very important issue. Corinne, it's all you.
Thank you so much. Sometimes it's easier to talk to a crowd of people that you don't know at all, but I'm looking around at these faces, and so many of you have been, well, not so many, but a few of you have been on this journey with me for a long time. In particular, Dick Gilbert has been at this longer than me, and so it always makes me a tiny bit nervous. But he's always so supportive, and I know he'll jump in with any corrections or clarifying questions. And also, Sally, thank you for being here. I just, our mutual shared friend who passed, it always brings a little emotion to the thing for me, right? So thank you. Well, I am very excited to be here and so grateful for the support of NYUUJ on this issue. The Unitarians have been out front on this issue for a very long time, and for that I am grateful. We are 8.5 years into this campaign. This is the most difficult part of any legislative campaign, when you are up to the place where you've done as much persuading as you can, and now it's really trying to get it over the finish line. And so that's what I want to share with you this evening, how we're going to get this over the finish line. So I'm going to share my screen. There we go. Hopefully this works. Yeah, so thank you. I'm going to pause sort of in the middle, in between each of the sections that I go over to see if folks have questions. But since I'm sharing my screen, I may not be able to see. So I'm going to need some help from you, Ashley, in seeing whether there are questions. Just by way of introduction, in terms of what we'll cover tonight, I'll do a quick introduction to who I am and who Compassion and Choices is. I'll do an overview of the legislation for those of you who are new to this, and we'll go through that quickly. And if there are questions that you have, please don't be shy in asking them, because it's always helpful for me to hear what the questions are, but as a reminder to others. Then we'll talk about the process, what procedurally it's going to take to get this bill into law in New York. I'd like to address how we look at medical aid in dying through a health justice lens just a little bit, two particular issues, which is addressing issues of race and disability. Then we'll talk about what Compassion and Choices is doing to prepare for the 2024 legislative session. I'd like to, since you've got such a wide diversity of people from all over the state, talk to you about the different buckets of lawmakers and where they stand, from supporters to people on the fence to lawmakers that we consider problematic, so that you can, if you recognize these names or regions, we can do some deep dives into that. And then finally, what advocates can do to help get this bill over the finish line. Does that sound like a good agenda to people?
Yes.
Great. So just in terms of me, as I said, my name is Corinne Carey, and I'm the Senior Campaign Director for Compassion and Choices in both New York and New Jersey. Being in that position and helping with implementation efforts in New Jersey gives me a very unique vantage point. The fight in New Jersey was not nearly as difficult as it's been in New York. As a New Yorker, I can say I just think that New Yorkers are a lot more skeptical, and you can answer our questions one day, but we're going to have more the next day. And for some reason, that just was not the case in New Jersey. The opposition wasn't nearly as organized in New Jersey either. But one thing that I take heart in terms of what I've seen in New Jersey is that, you know, there was opposition there. It took 8 long years to get the bill passed in New Jersey, so we're not too far behind. The minute that that bill passed in New Jersey, the opposition all but disappeared. There was a lawsuit filed, but it was a fringe religious group. And the folks that we had a hard time getting an audience with, like the hospice and palliative care group in New Jersey, some of the faith groups, they immediately contacted us and wanted an in-service after that law passed. So it was just, it was incredible to see the frenzy of what looked like a robust debate right before the law passed, and then how the opposition kind of melted away and people just saw it as something that they needed to get up to speed on. So I think it will probably look a little bit different in New York, but watching the gratitude that constituents in New Jersey have for their lawmakers there, watching the peace that this option has brought to families, watching how the Murphy administration jumped in and really did a tremendous job at putting up information that helped educate people about the option. We've already started to have those conversations in New York with counterparts in New York's government. So I'm feeling really good about that. And I think we're going to be ready when this law passes. In terms of Compassion and Choices, we're an organization. It's a national nonprofit organization. We work to improve care, expand options, and empower everyone to chart their own end-of-life journey. We affirm the value of life, and we accept the inevitability of death. And that's what really drives our work. We do a whole lot more than just medical aid in dying. And if folks are interested in bringing some of our resources to your communities in terms of advanced care planning, I would love to work with you on that. So we do a lot of community education on advanced care planning, how to choose a hospice, how to choose a health proxy. We help people plan for the care that they might want should they get a diagnosis of dementia or Alzheimer's. We also do a lot of education around what is hospice, what is palliative care, how do you access those options. We run an end-of-life consultation service for people and their families, no matter where they live. You can call our 1-800 number, which is a warm line, which means that, a family member or a person with a serious or terminal diagnosis can call, leave their name, number, where they're calling from, and our consultation specialists will talk them through what their end-of-life options are. We support healthcare professionals, nurses, pharmacists, hospice providers, clinicians in delivering the best possible care, no matter where they are practicing. We also engage in legal advocacy, bringing impact litigation cases on behalf of individuals and their families when advanced care plans are not followed, when people's wishes are not respected at the end of their lives. And we do a ton of policy advocacy at the federal level and all across the states, trying to improve end-of-life care. So, for example, I sit on the end-of-life subgroup of the governor's master plan on aging, coming up with a series of recommendations for how to improve end-of-life care, separate and apart from medical aid in dying. So it's a large docket of work that we do at CNC. Sometimes it feels like medical aid in dying is just a small slice of that, but we're going to focus on that tonight. I'm not going to pause here for any questions. If you'd like to get in touch with me about some of these other programs, my contact information will be available at the end, and you can always reach me through Ashley. So an overview of the legislation. New York's Medical Aid in Dying Act would allow a terminally ill, mentally capable adult to request medication from a doctor that that person can take at a time of his or her own choosing, or never, so that they can die peacefully. And one of the important parts of the law is that you must be able to self-ingest the medication. You must be able to take the medication into your body on your own. That is basically what we're talking about. This is the broad outline of what the legislation would do. It was first introduced in 2015. There were several versions of the bill bouncing around the legislature. They were sponsored by a bipartisan group of lawmakers. And when I took this position in 2015, I brought everyone to the table. End of Life Choices New York, which is another group focusing on improving end-of-life care, all of the bill sponsors. We looked at all of the evidence from across the country about how, at that point, only 4 states had been implementing the law. And we decided who would be the strongest bill sponsor to carry the bill. It turned out to be Assemblymember Amy Paulin from Scarsdale and Senator Diane Savino at the time. And the bill was reintroduced with the name the Medical Aid in Dying Act in 2016. It very shortly thereafter was passed by the Assembly Health Committee, in part due to the impassioned testimony of then Republican Assemblymember Janet Dupree, who is a real hero of this movement. She lost both her mom and her dad in ways that were particularly horrific. And she relayed that story to her colleagues, and they could do nothing but vote yes on this bill. So the bill moved through the Health Committee, and then that is where the motion stopped. And we have not seen movement on the bill since. That's not entirely unusual for legislation of this import. Many times legislative leaders don't want a bill to pass through one house's health committee and then sit for a long time. And so rather than having it move incrementally each legislative session, they have been waiting for all the ducks to be in a row. The bill has been along the way amended 4 different times in ways that I think strengthen some of the provisions around the voluntary nature of this legislation, strengthened also in terms of the information that needs to be provided to people about alternatives to medical aid in dying. This past year, one of the most major amendments was made that require both witnesses to be people who don't stand to benefit from the person's estate. It used to be that only one witness needed to be someone that wouldn't stand to benefit. So that was an important change that brought on new legislative support. And at this point, the bill is publicly supported by virtue of people putting their names on as co-sponsors by 83 members, which is really impressive, 63 in the Assembly and 20 in the Senate. And this, what's more remarkable than the number is the diversity of bill sponsors. We've got people from upstate, downstate, central New York, western New York, the North Country. We've got, or maybe we don't have any in the North Country. I think we don't. I think we have nobody in the North Country. You know, people of different faith backgrounds. More than 60% of our bill sponsors, which I'll talk about later, are people of color in the legislature. And it's a great mix of super progressive people who are new to the legislature and people who've been representing their communities for a very long time. So the diversity is, as I said, remarkable for all of those reasons. The core eligibility requirements of the Medical Aid in Dying Act mirror those in every other state that has passed a medical aid in dying law. So in 1994, Oregon became the first state to pass one of these laws by voter referendum. Unfortunately, we don't have a voter referendum system that allows for groups to put something like this on the ballot in New York, or else I think we would have had this law pass a long time ago. But it's notable that since Oregon was, I don't know if you've heard of this phrase, the laboratory of the states, where, you know, a state picks up an idea, runs with it, and then every state works to improve on it after that. what's incredible about Oregon's law is that these core eligibility guidelines have worked for more than a quarter of a century, and the law has never had to be amended in terms of these eligibility guidelines. So every state in the United States that has a law like this requires that someone be an adult, 18 years of age or older, with a terminal illness, and in the New York bill, it's defined as an illness that is incurable and irreversible, with a prognosis of 6 months or less to live. The person requesting medical aid in dying also has to be mentally capable of making their own healthcare decisions and acting voluntarily. And as I mentioned earlier, they have to be able to self-ingest the medication. And we can talk about that in more detail if you've got questions about that, which many people do. And I'll pause in a moment. But the safeguards are myriad. There are more than a dozen safeguards, and you're not meant to read this whole thing, but I will highlight just a few. One is that if either doctor has any concerns about the patient's mental capacity for such a decision, they have to make a referral to a mental health professional for an assessment, and no medication can be prescribed to that person unless and until mental capacity is determined. In addition, the attending physician has to inform the requesting patient about all of their end-of-life care options, including hospice and pain and symptom management. The patient must be able to take the medication themselves, as I said, and the other really important safeguard is that the law is entirely voluntary for everyone. There is a very strong conscience clause opt-out provision that says that no physician, no healthcare provider, no pharmacist, no hospice, no facility is required to participate in medical aid in dying. This actually turns out to be a huge barrier to care, but it is politically very important to lawmakers that no one is forced to participate. Likewise, the decision for medical aid in dying comes from the patient themselves. It's not suggested by the doctor. A family member, a health proxy cannot make a request on behalf of a dying person. The dying person themselves has to make that request. Just a few updates for those of you who have heard this talk before. That we track the statistics every year that one of these states puts out a report to its legislature about how these laws are working. And year in and year out, we find that very few people actually use medical aid in dying. Less than 1% of those who die in authorized states actually use the law. And the most recent report from New Jersey shows that about 186 people have used the law since it took effect in 2019, which constitutes about 3.5 years of reporting. Terminal cancer accounts for the vast majority of qualifying diagnoses, with neurodegenerative diseases like ALS or Huntington's following as the second leading diagnosis. And that's important because of what I said earlier about self-ingestion. There are a number of people who believe that these laws discriminate or prevent people with these neurodegenerative diseases from accessing medical aid in dying. But in fact, there are so many methods that physicians have devised to allow people to take that last decisional act of bringing the medication into their body that people who have difficulty holding a glass or sucking through a straw still have means of administering the medication to themselves. So I thought that was important to note. And then, survey after survey shows that most people, when they envision their own death, they want to die at home. Not everyone, but most Americans do. And in fact, these laws enable about 90% of people who use them to actually die at home. It's also important to understand that more than 85% of people who obtained the prescription were receiving hospice care at the time that they died. So this is really important when you encounter opposition that really believes that medical aid in dying is an either or with hospice and palliative care. It's not. In states that have authorized these, medical aid in dying becomes just one part of a toolkit that hospice and palliative care providers have to offer people at the end of life. And also it's comforting, I think, to lawmakers to know that people aren't asking for medical aid in dying because they're not getting the care that they need from hospice and palliative care. Another thing that I want you to know is that about a third of those who receive a prescription never end up using it. Their families report that their loved ones felt a tremendous sense of peace of mind, just knowing that this was an option if their suffering became too great to bear. And what we see is that people are willing to take that one last trip with the family if they can. They're willing to engage in experimental treatments if they know that there's a door that they can open when their suffering becomes too great. I'm going to stop there and see if anyone has any questions about the bill provisions before we move on. Anyone? Ashley, I don't see any hands. Do you?
I'm scrolling through and I don't see any.
Okay. All right. So let me say a few words about the legislative process. The first thing that I want to mention, and this will be a theme throughout the rest of what I talk about, is that supportive lawmakers need to be public in their support. If you yourself have talked to a lawmaker and they say to you, yes, I'll vote for the bill when it comes to the floor, that is absolutely not enough. Legislative leaders know that lawmakers hide behind the promises that they make to constituents. And if they're not on the bill, that signals to lawmakers that they're not comfortable in their support. So we need to start to see more lawmakers who've said that they'll vote yes, put their name on the bill. Lawmakers are then, the legislative leaders will be willing to what they call conference the bill. And that means that they'll gather members of their own party into a closed door session where they really get a sense of where their colleagues stand, and they make sure that if they put the bill up for a vote, it will not fail. The New York State legislature is a lot more Byzantine and top-down controlled than a lot of other states. And so where you see robust legislative debates in other states where supporters are sitting at the edge of their seats wondering whether the bill will pass or not, that does not really happen in New York. If a bill is placed on the floor, it's placed on the floor because the leadership is confident that it will pass. And we've seen this with reproductive health. We've seen it with marriage equality, the Gender Expression Non-Discrimination Act, the Family Healthcare Decisions Act. Those bills didn't come up for a vote and fail year after year. They just simply didn't come up for a vote. So that conference is critical and needs to happen. And the bill was on the verge of being conferenced last year. And in fact, there was an informal conference when one of the legislative leaders was absent from Albany. And when she was asked about it by the press, she said the bill was not conferenced because she was not there. So that conference is a really critical step. That isn't actually enshrined in any law. It is just custom in New York. The bill then needs to move through several committees in both chambers of the legislature. In both the Assembly and the Senate, it will have to go through health, the Health Committee in the Assembly and the Senate, and then through the Codes Committee in both chambers. It's unlikely to have to go through any other committee like insurance or aging, but the leadership could change that. But to the best of our understanding is that these are the only two committees that it would have to go through. If the bill passed in the final days of a legislative session, it would not have to go through committee, and that's probably what would have happened last year, is it would go through what's called the Rules Committee and directly to the floor. But because of what 2024 will look like, which I'll talk about in a second, we're likely to see the bill go through Health and Codes and not Rules. The bill has to pass both chambers in the same legislative session in the same exact form. So sometimes legislative campaigns have the problem where the bill doesn't match in both chambers. We do not have that problem. Our bill sponsors work really, really well together. So whenever there have been amendments, each house has amended the bill in turn, and we've always had a same as. And that's what they call them, same as, when the bills are identical in both chambers. And then if and when the bill passes both chambers, say it passes in the Assembly first, then it's sent to the Senate passes it and sends it back to the Assembly. And then it will be the Assembly that decides when to send it to the governor, who can either sign or veto it. And there's some complicated rules at the end where if she doesn't sign or veto it, something happens, but within certain time deadlines. So we'll cross that bridge when we get to it. I actually have faith in Governor Hochul, even though we have to keep the pressure on her, that she will do the right thing when the bill comes to her desk. I do not expect her to take a public position on this issue prior to the legislature passing the bill. So if you are someone who is waiting for the governor to take a position and thinking that that's going to move the legislature, there is 98% chance that that is not going to happen. The governor will not get ahead of the legislature on this issue. Now, if the bill isn't passed by the end of the session, will be June 2024, it will die, and it will need to be reintroduced in 2025. And we will have to redo all of the work to get those bill sponsors back on the bill. And we'll also be dealing with a new cast of characters at that point. So hopefully some of the problematic lawmakers that I'll talk about in a moment will have shifted. And I know that that will be the case for at least some of them. I'm going to stop there and ask if people have any questions about the legislative process before I move on. Looking around. Any questions? Either you're all tired at the end of a long day, or I'm doing a darn good job of explaining this complicated stuff. Dave Monroe. Hi, Dave. It's been a long time.
Yeah, how are you? Not legislative process per se, but I read that the New York State Bar Association has put together a task force to look at this. Do you know the status of that? Is there an upside to that or a downside, or what can you say about that?
Well, I can say that it's been occupying a ton of my time over the past few months. So you are right. The New York State Bar Association assembled a task force. And unfortunately, the task force is chaired by an avowed opponent of medical aid in dying. How that happened is the story for a novella, which someone, if they had time, would write it. But it's a worrisome process. I do have faith in the leadership of the New York State Bar Association that they will not allow a report to come out that is inconsistent with the evidence. And if the report comes out with, massive concerns, it will be inconsistent with the evidence that task force has thus far heard. So I am worried about the first draft of the report. I am less worried about the ultimate result because I do have faith that these folks have some fidelity to fact. And I also know that there will be an open forum that the task force will be hearing testimony from people who managed to register before the registration was filled, which I think it was a couple of hours after it was released. I think that that's going to be fantastic. It's not going to be public. It may be open to members of the bar, but there's no way for the general public to watch it. So looks like, is it Theo or Teo has a question?
It is Theo. Thank you very much. And it may be an obvious one. I worked at hospice for 30 years, but as a bereavement services manager, but and you may have already answered it, but the one thing I observed with our families was the difficulty managing some of the medicine, and especially in certain neighborhoods. So I was just wondering the responsibility of having that medication in the home and what it is, if that's something people get hung up on.
Yeah, so it's always a question we get from lawmakers, and I say a few things. First and foremost, there has never been a mishap with the medication in terms of the medication getting into the wrong hands in any state. So we've never seen someone accidentally ingest the medication. It has no street value, unlike some of the other medications that we send people home on hospice. It's also pretty complicated. So one needs to take preparatory medication prior to taking the medication that ends someone's life. So you need to take an anti-nauseal and a pro-absorption drug. Most people don't even pick up the medication until they're ready to take it, in part because it can be expensive, and in part because they just don't want it in the house. There are strict take-back provisions. So, for example, when my dad died, there was a ton of morphine in the house, and we were advised by hospice to put it in cat litter and throw it in the trash, which is just terrible. The bill requires that there be a take-back program for the medication that's unused, but it's unlikely that the medication is picked up and unused. But for those cases where there is, I feel like I hit all of the questions that you asked. Yes. Okay, good. Dick, you've got your hand up. Oh, you're on mute.
I just found an article that the AMA legislative body is to consider reversing its opposition to, unfortunately, they say assisted suicide, but they are reviewing their point of view, so that may be helpful if they should change their view. Some doctors groups have supported it, and apparently others have opposed it. So you can get up to date on that. But I thought this is a hopeful sign.
It is, and we have a coordinator of our Doctors for Dignity program, Dr. Rebecca Thoman, and she's been working for years to get to this point. And I feel like she's optimistic on this. The AMA, in a very convoluted statement, moved from opposing medical aid in dying to supporting physicians in states that authorize medical aid in dying and delivering that care, which was a very subtle change, which didn't mean that the AMA went neutral, but it certainly was not in strict opposition anymore a couple of years ago. And this would be a dramatic change that would garner all kinds of headlines. And the story that we saw, I think it was in the Catholic Register and the New York Sun, was the language was just terrible. But we were happy to see that this is actually happening. And I think, as you said, I think it's going to make a big difference. The Medical Society of the state of New York, I don't think will ever change their position from opposition, but the largest subgroup of MSNY, which is the Medical Society of the state of New York, is the New York State Academy of Family Physicians. And they are not only supportive, they are champions of this legislation. And in fact, the president of the New York State Academy of Family Physicians was one of the first people that the NYSBA task force heard testimony from. So thank you for raising that. Any other questions about the process before we move on? Okay, so two issues, not just two in terms of health justice, looking at this through a health justice lens, but two of several issues that have been raised over the past few years about this bill are: where do communities of color stand on medical aid in dying? And what about the strident opposition from some leaders in the disability rights community? And I'm going to try to address some of the issues here briefly, and we can have a discussion. But first, I will say that there is a common misperception that that BIPOC people, that people of color, that Black New Yorkers, Latinos oppose medical aid in dying. In every bit of polling that we have ever seen, there is majority support among every subgroup. Now, there is sometimes a slight dip in support among Black New Yorkers for this, and that could be attributable to, and I know it is attributable to a whole host of factors. One of which is a well understood distrust in the medical establishment, that that doctors are not to be. We can't put all of our trust in doctors, that terrible things have happened when we do, and that people may be getting substandard care. We know, for example, that while people have the right to access all curative treatment at the end of their lives, they may not have the financial ability to do that. And so if you are unable to access the gold standard of cancer care or even palliative or hospice care, will that push people to opt for the easier solution of medical aid in dying? And to that, we often have to talk about the fact that, do we wait to open options up to everyone until we have fixed all of the inequities in the healthcare system? And what would that mean? That would mean that no one should have access to hospice and palliative care because some people can't access it. So for an organization like yours, I know you support healthcare for all, the universal healthcare bill, which the name of which is just escaping me at the moment, but the universal healthcare in New York. I do as well as a person. Compassionate Choices has been looking at expanding our mission to support legislation like that. Personally, we all do. So we can do two things at the same time. We can work to improve care, and we can also open up these options. It's important to know that 60% of lawmakers who sponsor the bill in the legislature are lawmakers of color, and that was not won easily. This was the question that all of these lawmakers asked us when we sat down and met with them. Some of you may have been in the room when these questions came up. That support was hard won, and I think that those lawmakers acknowledge that we need to be improving care on all fronts. It is also a fact that very few people of color utilize the law. So on the one hand, there are people who are concerned that people of color will be pushed into choosing this option because of a lack of other options. But in fact, it's just not played out this way. So why is it that the statistics show that the majority of people who use medical aid in dying are white people, are older white people, are white people who have advanced degree, who have at least a college degree or more? It's because of this issue of health literacy. In order to access an option like this, you have to be aware of it. And you have to advocate for yourself. I don't know how many of you have been with a loved one at the end of life or dealing with a serious illness, but my goodness, you have to be an advocate for yourself, and you have to understand the healthcare system. And so many people don't. And so awareness and health literacy is one piece of it. Culture is another. Health equity doesn't mean that equal numbers of people or equal proportions of people are using the law. And it may always be that because of issues of religion or culture, that a lower proportion of people use medical aid in dying. It just may not be culturally appropriate for some groups. Where equity comes in is making sure that people have access to all of their options and that they're aware of all of their options. Another barrier to people receiving care, and one reason why some people of color in other states may not be using it, is the payment system. In all but 4 states that have authorized medical aid in dying, there is no public support for it. And so if you don't have private health insurance and you're on Medicaid or Medicare or the VA, in all but 4 states, the cost of care under medical aid in dying laws is not covered. California, New Mexico, Hawaii, I'm not remembering the last one. There are 4 states that have used state Medicaid dollars to cover the cost of care. And that has gone a long way to opening up access to different, to people who would not otherwise be able to afford it. So that's what I would have to say about race for now, although we could do a lot more talking about that. I just want to show that, like, the desire for patient autonomy at the end of life is universal. These are just some of the folks that have stepped forward with public support for medical aid in dying. We've lost some of them. I just realized now I didn't update the Tina Turner or the Desmond Tutu slide to show that they have since passed. But I think about all the times that I've been at public events and I've had people of color come to the table and say, oh no, this is not something I believe in. And then if you spend moments with them, one-on-one, 5 minutes, 10 minutes, you hear the most striking stories about suffering at the end of life. And almost everyone walks away knowing that they support this option, even if it's not for them. So I wanted to mention that, you know, this desire for patient autonomy, but also the desire to not see your loved ones suffer is shared by every group I've ever spoken to. All right, so moving on from race, let's talk about disability for a moment. New polling came out this year from a group called Us for Autonomy, which is a group that has been founded and led by people living with disabilities, that shows that 79% of people living with a disability support medical aid in dying. So even a greater percentage than the general public. 73% of people who live with someone with a disability support this option. And then if you look at that polling information, there's even diverse support there. So 65% of Republicans who are living with a disability, 79% of disabled Democrats, 83% of independents. And then, you know, here with race, 82% of disabled African Americans, 81% of disabled Latinos, and 75% of disabled whites. I can't explain the disparity in those numbers, but the support you can see is strong and clear. So across the country, an increasing number of disability rights groups have taken a neutral or supportive position on medical aid in dying. The ARC of New York, which is our largest and oldest disability rights group, Disability Rights Oregon, which has seen this law play out for many years, a disability rights group in I can't even read that because it's blurry, I apologize. I can't remember where that's from, not New York, Disability Rights New Mexico, and the Resource Center for Independent Living, which is the largest advocacy and services organization, independent living center in New York State. And why is that? It's because the movement to expand end-of-life care options and the disability rights movement share important core values of autonomy, independence, and self-determination. We had an advocate that I worked closely with for many years, Gene Hughes from RCIL, and he said, you know, people living with disabilities have fought for decades for the right to make their own decisions at the end of life. To think that they are too vulnerable and weak to make this decision at the end is just insulting and inconsistent with their fight. So, am I saying anything more about that? No. I think what's hard is that sometimes the loudest voices determine the debate. And so it looks like people living with disabilities oppose this because some of the loudest voices in opposition come from the disability rights community, but it is actually a very small number of people. In the early days of this campaign, we used to find it very easy to find someone to debate. Now, there is no one who will debate this from the disability rights community, except maybe one person from a group called Not Dead Yet. Most of the time they're bringing in people from other states to speak at public forums and in opposition to this. So it is a problem that we have to contend with. Lawmakers say that the worst days of their legislative lives are when disability rights groups circle the elevators and talk about genocide, which is what they will do when this bill starts to move. So it's something that we need to be prepared for and to meet with compassion, because I think that these leaders are doing a grave disservice to the rest of the community of people living with disabilities, making them fear for their very lives once this law is passed. And we know through over a quarter of a century of evidence that, you know, there have been no reports of coercion or misuse of these laws against people living with disabilities, and no serious effort to expand the eligibility criteria to make medical aid in dying available to anyone other than a terminally ill person with a 6-month prognosis. So I will stop there and see if folks have questions or statements they want to make or issues they want to raise before I move on. Anyone? Through. Okay, well, I will move on then. And I will tell you what our 2024 legislative campaign will look like. So 2024 is an election year. That means that every single assembly seat, every single senator is up for re-election in 2024. It's huge. And generally speaking, as a rule, lawmakers do not take up controversial bills in an election year. But I thought you just said the polling information shows that this is not controversial. Yes, that is true, but this bill has been labeled a controversial bill. The media feeds into that by calling it controversial. And no matter what we say about the polling, it is, for these purposes, a controversial bill. We have a good but narrow opportunity this year, pre-budget. The budget needs to get passed by April 1st, and generally speaking, in January and February to move this bill. We have a soft commitment from the Senate Majority Leader to bring this bill up during that time, and we're focusing all of our effort on those 2 months. Last year was the first year that we had a solid roster of legislative champions. And what I mean by that is we have a number of lawmakers who are willing to stand up publicly and talk about how important it is for this bill to pass. And we also had the votes to pass it last year. So why didn't it pass last year? It's a complicated problem that there are some lawmakers who have told their constituents, and they've told us, that they will vote yes when this bill comes to the floor, but they don't want the bill to come to the floor. There is what we're colloquially calling an ick factor with this bill. Nobody wants to debate it. Well, not nobody, but there's a too large group of lawmakers that don't want to debate it. They don't want to talk about death. They don't want to talk about suffering. It's a bummer. It's going to be a long and difficult and emotional debate, and they don't want to do it. They don't want to put themselves in a position of taking a public stand, even though they know it's the right thing to do, and they know that it would be inconsistent for them to do anything otherwise in terms of their votes on bodily autonomy. And so they've gone to leadership and said, yep, I will vote for the bill, but I don't want to. Please don't make me take this vote. And that is a huge problem. It's an invisible problem, and it's very hard to overcome. So what we did during the summer is we hired a new public relations firm, and they are helping us to shift our message away from death and suffering. Last year, our tagline was "Death is inevitable, suffering doesn't have to be." We're shifting that message to love and family and compassion and gift. What a gift this would be for lawmakers to give their constituents, because we have an increasing number of New Yorkers who have experiences with loved ones who've accessed medical aid and dying in other states. And those stories are so heartwarming, and we've watched the effect that those stories have had on lawmakers. So we're trying to lift those voices and make this something that people can feel good about and not terrible about. So we're not going to be blaming lawmakers for letting people die and suffering this year like we did last year. We're going to be encouraging them that they could do this for their constituents and give them the gift of love. We, many of you, I don't know how many, but some of you may have seen that we did a large-scale display in the Legislative Office Building in Albany, and we're going to be doing that again this year. We're revamping those 8-foot by 4-foot boards that make a visual case for passing the bill. Those boards will be on display from January 16th to the 20th, and we're having our big lobby day on January 16th. We need as many people to descend on Albany that day as possible. We're going to have a press conference, a rally. We'll hear from our bill sponsors, and then we'll break up into small groups and either go visit target lawmakers, which we'll talk about in a moment, or do rallies outside of both the Assembly and the Senate. So you'll be divided into different groups to do those different things depending on who represents you in the legislature. And then in terms of communicating with lawmakers this year, we are moving away from a form letter format. So in the past, we've sent people to a link and we've asked them to fill out a form letter, and those emails go to lawmakers. We're moving away from that, although not entirely, because that's always going to have to be part of our campaign. But we are encouraging people to use their very own words, their own pens, their own computers, their own envelopes, their own ways of speaking to generate organic communications into lawmakers' offices. So how does that play out? That means that when you want to register your opinion with your own representative, I don't care whether you call it medical aided dying or assisted suicide or death with dignity. I don't care what talking points you use. You don't have to have the bill number. You don't have to have anything. You just have to tell lawmakers something in this realm that you want them to prioritize, because everyone at this point knows that medical aid and dying is on the table. So you don't need coaching from me about the language to use. If you feel it in your heart that you want them to do this, you need to speak from your heart. Last year when we delivered petition signatures, someone suggested that we take the box back and put all of those signatures that were on separate pieces of paper in different colored envelopes, and it would look better. We weren't going to do that. We decided we were going to shift this year to these more organic communications. So if you took out some note cards from your storage, because so much of our communication is electronic now, and you hosted a little letter writing party in your living room like we all did during the 2016 and 20 elections, that would be tremendous. We're also focusing on district offices instead of sending all communications through Albany. So if you're making calls to lawmakers, you'll be calling their district office instead of their Albany office. And then finally, another change is emphasizing the personal, talking about why this matters to you as opposed to the facts. No, it doesn't matter what the polling numbers are. It matters what you think and what's in your heart, and communicating that to lawmakers will be very important in 2024. So what can you do? Letters to the editor between now and the end of the year. I know that people have heard me say that before, but we want to flood these papers, and they're not going to publish every one of them, but if they see a flood, they might issue an editorial in support of the bill, and they'll publish some if they get a flood. So if you would like to write a letter to the editor and you're not sure what to say, please reach out to me. We've got a team of communications professionals that will help take your words and turn them into a gorgeous short letter to the editor that will be something that the editors will look at and publish. It's kind of formulaic, so there's a way to do it. There's an art to it, and if you want to learn that art, or just have your words turned into art, let me know and we'll make it happen. We can also advise you about the local publications that will accept letters to the editor. Meeting with lawmakers who are on the fence. If you would like to convene a group of people to go meet with one of those on the fence lawmakers, I will coach you in how to design a successful legislative meeting and what to bring to that meeting and how to make it happen. Also meet with lawmakers who are opposed. They don't get a free pass. They need to hear from people who are supportive. Likewise, I can help you make that request. It would be so much better if groups organically requested those meetings rather than having CNC request them this year. So we're really asking people to step up and do that with our support if you'd like it. Hosting letter writing parties. I meant it. I myself have a closet full of stationery that I no longer use because electronic communications are so easy. If you yourself have that closet full of note cards and stationery, host a party. Get people to literally put pen to paper, put stamps on envelopes, and send these in. These will have a bigger impact than any electronic communications that we drive in. The next big thing is come to Albany on January 16th. We're going to try to help people with transportation, but if folks can carpool or bring some resources to bear to bring a bus from a different region, having people come to Albany on January 16th would be tremendous. We also have a selfie video and a selfie photo project. So if you feel like you could hold up your cell phone and do a selfie video or a selfie photo holding a sign or expressing support, we could could really use that. We're going to be doing an I Am a New York Voter video that's going to come out in January or February, and we could use more footage for that. So if you're interested, let me know. And then finally, hosting community discussions. Last year, I did a winter tour where we hosted community conversations in church basements and Rotary clubs all over the state, and it was fantastic. So if you'd like to do that, we have templates for how to do it, and video resources, documentaries, screenings of the Emmy-nominated Last Flight Home full-length documentary. If you'd like to do stuff like that, we can help you arrange it. So that is it. And I feel like I went over, but thank you for the time. And that is my contact information. I'd be happy to answer any questions now or whenever they come up for you.
Thank you so much for taking time to be with us tonight.
The
Corinne.
woman talking right now is the woman that Odette connected me with last year. Yeah.
Thank you so much for all of this information. I feel like you've given us so much to think about, so much to consider. I very much appreciate you taking your time to be here tonight. I recognize the time that we have, that we've gone a little bit over, and so there's just sort of two things that I'd like to do before we close out for the evening.
I'm just reading everybody's comments and then I'm going to go.
Yes, of course. First of all, for those of you who are still here, please take note of Corinne's information. If you have any questions that you would like that, thank you, Corinne. If you have any questions or anything like that, please feel free to contact her. In the chat right now, I'm putting two links. One is for if you would like to contact any of your representatives. They may be moving away from form emails. We still have them. So if you would like to contact representatives in that way, we have a link for you to be able to do that. tinyurl.com/NYUUJMAID. We also have tinyurl.com/NYUUJ lookup lawmaker, so that if you would like to look up who you are represented by so that you can contact them in another form, you will be able to do that. So if you look in the chat right now, both those links are available for you to do that. And I would like to close out our evening by inviting Dick Gilbert to give us a few words on his experience doing the work of medical aid in dying. If he's still here, I think he's still here.
He's still here.
Yes, wonderful. Give me 1 second, and I'm going to try and spotlight you so you can say a few words about your work. I know that you've done a lot, and I appreciate you being here tonight.
Thank you.
There you are.
Well, I am here, yes. Corinne has done her usual great job, and I hope it'll be available, and I'm sure it will be in some PowerPoint form. Just a quick UU perspective on this. The UUA did its first resolution supporting medical aid in dying in 1988. This is important for two reasons. One, because a religious group, as a group, did it, our whole denomination. And two, it was so many years ago that we've been struggling with this particular issue. So that gives you a little historical perspective. Ralph Merrow, back in those days, some of you may remember, some of the old timers remember Ralph. He was the organizer, UU minister, organizer in, I think, the state of Washington for medical aid in dying, or Oregon, I'm not sure which one. Anyway, I preached my first sermon on April 30th, 1989, Do We Have a Duty to Die? And I've given probably a dozen sermons and talks on it since. The most recent one over at RIT to a retired group. This is a retired group of people. They have come in for education on various issues. Just a couple important points. One is, I think those of you who are ministers, it would be good for you to preach on this subject. I don't care how well you're persuaded you are by the presentation tonight, but when you preach on it and do your usual research around the internet as well as in your own heart, it will be a great experience for you to clarify your own mind. Doing so, you will have automatically the makings of a letter to the editor and an op-ed piece all ready to go almost. So that's a good experience. For those of you who are lay people, encourage your minister to speak on this topic. I'll lead sessions on it. I used to lead a session on death annually at First Unitarian, and this was one of the topics that was always covered. Just doing a quick look at other notes. The most important thing, I think, in preaching and talking with your officials and so forth is experiences. I've done that, 2 experiences in particular. Judy Wells, a ministerial colleague of mine, who moved from Pennsylvania to Oregon to take advantage of their medical aid in dying. She celebrated her 77th birthday in the fall of 2020, hoped to be able to stay alive to vote, couldn't make it, but on her last day of life in the morning, she wrote letters to people in Pennsylvania urging them to vote. She took the cocktail with her family and friends that afternoon, but what a way to go. So that's one experience. Another experience, a minister, one of our UU ministers in Canada, is writing a PhD thesis on this topic. His wife took advantage of Canada's much more liberal medical aid in dying legislation. I think it's important to talk about a continuum of care. To head right into medical aid in dying, point blank, maybe a bit much for some people. I went to the Jewish Community Federation yesterday for my old friend David Levin, who gave a talk. He's a lawyer and head of end-of-life choices in New York, or head emeritus, I think he is. And he did a nice job of talking about pain management, pain mitigation, palliative care, hospice, and medical aid in dying as a kind of continuum. And I think that's a good way to go at it instead of point blank doing medical aid in dying, which may be too much for some people. He talked about molds, which I think is another avenue to get where people are. Medical orders for sustaining life treatment, I think, is the full thing. It's a New York State legal document. You can fill it out. It gives you great detail about what treatment you want at the end of life. It doesn't go to medical aid in dying, but it gets you to talking about it. Then I was amused with Corinne's talk about groups of legislators. I think of Mitt Romney's thing. And so I say there are binders of legislators around for us to deal with. And I think it's important to get the people in our own areas on board and organize meetings to talk with them. So I think that 1988 resolution is something that you ought to all have in your computers. And I think it's the kind of thing that ought to be up on the NYUUJ website, if it isn't already. I haven't checked it lately, but things of that sort. And that's about all I have to say. Just thanks to Corinne for her patience in modeling how to keep after an issue through defeat after defeat. And she still keeps at it, and she adds new information and inspiration every time she talks. Thanks.
Thank you, Dick, and thank you all for coming out tonight. Thank you all for those of you who stuck in there for the extra 15 minutes. And as you just mentioned, having time to organize and to talk to one another is always great. So we're gonna give you all some space if you'd like, have some rooms open for you to discuss anything that you have heard tonight by region. You are not required, obviously, to stay for those, but I'm gonna have that up for anyone who would like to opt in. So we'll have some breakout rooms open for you if you would like to stay and chat. But otherwise, we thank you all for coming tonight, and we wish you all a good night, and stay on the lookout for more information and for the next event for NYUUJ. Thanks, everyone.
Thank you,
I'd like to
Ashley.
thank Ashley for her leadership on this topic as well. as a member of the New York State UU Justice Group. Thank you, Ashley, for your great chairing of this and co-hosting with Corinne. That was really lovely. Thank you for that. Appreciate it. And thank you, Dick Gilbert, for your long-lived service on behalf of all of us and our core beliefs about who we as human beings are called to be: compassionate and just. Thank you again, everyone.
Thank you.